What does it take to become one of the most world-renowned, influential figures in pituitary medicine? How about building one of the nation's premier pituitary centers, training the next generation of endocrinologists, leading major medical education programs, publishing groundbreaking research, and dedicating your career to improving the lives of people living with pituitary disorders? Dr. Larry Katznelson has done all of that and more. Dr. Katznelson, welcome to Talking Acromegaly and Pituitary with Tony. I am excited you have joined me today.
Why, thank you, Tony. It's an honor for me to be here, and I'm deeply appreciative and grateful for the invitation.
So let's jump right in. I want to begin by talking about the incredible experience I had a month ago at the Stanford Pituitary Patient Education Day. My wife Stacy and I had the pleasure of meeting you in person for the very first time. And to make the experience even more meaningful, I had the honor of sharing the stage with you. It was truly a special moment for me, both as someone living with acromegaly and as an advocate. Can you take us back to the beginning and talk about the history of that event?
Sure. It was special for me to be at Stanford as well. I spent 20 years of my career there until just a couple of years ago. And I moved to Stanford in 2004 to build their pituitary program, which we did successfully. And one of the aspects of the growth of that program was starting these pituitary support education days, which I'd done before in my career when I was at Mass General in Boston. And we started again at Stanford. And our first career day, I believe, was around 20 years ago. And it was wonderful for me to be back with old colleagues, friends, and seeing some of my patients there at Stanford and also seeing you and meeting you there and sharing the stage with you. That was a very special moment for me as well.
I'm glad to hear that. Thank you so much. You've spent decades focused on pituitary disease. Was there a specific patient or a moment early in your career that made you passionate about acromegaly in particular?
Decade seems like a long time. I hadn't thought of it that way, but thank you. The uh, yeah, when I was training as an endocrinology fellow in Boston at Mass General, um, I went into my fellowship not knowing what part of endocrinology I wanted to practice or to research in or get engaged with. And then I saw my first patients with acromegaly, as well as Cushing's disease. These are these rare diseases that of the pituitary gland that have multiple manifestations, impact the body in so many ways, many of them negatively. And I thought, what a fascinating disease this is. It's a disease where we've uncovered the cause. We're getting much better at diagnosing it. We have found ways of treating this, and we can make a big difference in someone's life. And the disease I found so interesting, I decided to make it a career of mine, both in the research and clinical realm, as well as education. So I can't remember one patient per se, but it was just a few patients I saw that just sucked me in, saying, this is where I want to spend my career.
Dr. Katznelson, you have made a big difference in a lot of lives. You're now the Vice Dean of Medical Education at Cedars-Sinai. Are endocrinology fellows getting enough exposure to pituitary disorders, or is acromegaly still a condition that doesn't get enough attention in medical school and beyond?
Oh, that's such a good question. I don't think we've done enough in education to ensure that the medical community is sufficiently aware of what acromegaly is. And I've seen this from several different angles. I have done a lot of work over the years at the Endocrine Society to try to promote education in pituitary disorders, including acromegaly, at national conferences, regional conferences, clinics of endocrinologists and general physicians. We've worked hard at trying to dig into specialties that acromegaly patients may go to help in the diagnosis, such as gynecologists, podiatrists, dentists. We've worked that way, and even still, it's very, very hard to diagnose. As far as the fellows go, there's still a lot of education needs to be done. I'll give you an example. Not all medical centers that have endocrinology fellowships have adequate pituitary programs. So these fellows are not really getting highly educated in pituitary diseases. And I still teach to this day at other medical centers to try to train the fellows about acromegaly and pituitary disease in general, because we just don't do enough of it. We don't do enough of it, and we need to do a better job at it, for sure.
You've got a long list of accomplishments. I'm going to name just a few. Educator of the Year from the Endocrine Society in 2017. H. Jack Baskin Teaching Award from ACE in 2015. Distinguished Clinician Award from ACE in 2025. Past President of the Pituitary Society. You've chaired the task forces that wrote the clinical guidelines for acromegaly. What was the most contested or debated issue among experts when those guidelines were being written?
First off, I could just say you're around long enough, these awards tend to come. So I'm deeply grateful that I've been recognized for the work, but that's not why I went and did this. But it was nice to be recognized by my peers in this way. In terms of the contested issues, I think there's several layers of that. Uh, One, when we wrote the guidelines for acromegaly for the Endocrine Society, and similarly the consensus guidelines for ACE, as well as the Pituitary Society International consensus statements. I'm involved with those as well. Some of the issues that keep coming up include, how do we diagnose? What is the right growth hormone level that is considered high? How do we correlate the other tests we do for acromegaly, including IGF-1, with disease status, with the medical complications that occur with that? We still don't really know that. And that's important because we need to know that in terms of what our targets are when we treat somebody. And although we use normal ranges, are those really the correct normal ranges? And this topic keeps coming up when we're having our guidelines and task forces about um, what's the right method for diagnosing and monitoring patients on therapy. Another topic that keeps coming up is, which medical therapies to use and when. When I was training, uh, we didn't have that many options. We had surgery, and we had subcutaneous octreotide, which was given about 3 times a day, which meant that patients who were taking the subcutaneous octreotide knew when the dose was coming up in 8 hours because they started getting headaches and pains again. And this cycle kept happening throughout the day and throughout their time. And since then, there was a development of a vast number of medications. Really amazing what's happened with therapy for acromegaly over the last 25 years or so. But then the topic that comes up is how best to use these medicines. How do we know which is the right medication to use at which time? Which ones are cost effective to use for people depending upon their financial background? These are all topics that are, I wouldn't say highly contested, but highly discussed. They keep coming up.
You mentioned the 3 times a day octreotide. I started out taking octreotide 3 times a day, which was not
Yeah.
sustainable for me. In fact, you also mentioned IGF-1. I had the highest IGF-1 of anyone that I've spoken with. The day of my surgery, my IGF-1 was 1400. I'm in range now and I feel great. However, I did have a very high IGF-1. Let me ask you this. You were part of the major clinical trial testing a new way to deliver one of the main acromegaly medications. What did that study find, and what does it mean for patients who take the drug?
First off, I'd like to respond to something you said about yourself, that you were taking the 3 times a day octreotide. again, when I was training, that's what we had. And around the time I was a fellow, Novartis Pharmaceuticals was developing the artreotide long-acting release, or Sandostatin LAR, which was the first of our long-acting release medications, and it changed the whole approach to patients with acromegaly. It was the same drug, but now patients could take it and have even levels throughout the weeks. They weren't getting these headaches and pains and requiring to take the drug every 8 hours. Now they could work and function much better as partners, as employees, whatever they were doing. And it changed the whole approach to the disease. Um, and now there's several of these that are long-acting medications that are out there. And I think and in my experience, I've been involved in a number of trials at different levels. That includes Pegvisomant. I was on the original manuscript that was published looking at the use of Pegvisomant. So I was involved with that development, which is the growth hormone blocker. So it blocks growth from wherever it goes. And that was another dimension to treating acromegaly. Now we're not just treating the production of growth hormone by the pituitary tumor or whatever's left after surgery, but now we're blocking growth hormone wherever it goes. So now we're hitting two different levels of acromegaly treatment. So when we're developing that medication, that was just huge at the time because now we have a second level of targeting for our patients with medical therapy. And since then, it's been just a potpourri of medications, mostly aimed at the pituitary tumor itself. I've been involved in development, for example, of oral somatostatin analog type agents, well, those that hit the somatostatin targets that are oral, which for patients, it now frees them up. There's no injections, and these work in the majority of patients. So there are medications out there for treating the acromegaly that are oral. There's development of injections that are even longer acting, or easier for patients to take that patients can maybe even self-administer because the first long-acting preparations have been difficult for patients to self-administer. So I think what we have seen over the years, and has been my involvement with this, has been first, again, the development of several different levels of where we can attack the acromegaly with medical therapy. And the other one is medications that are getting easier and easier for patients to take. Um, so it's been groundbreaking compared to when I started with just the 3 times a day injection that you know well. And now with medications that are easier for self-injection, oral, several layers of attack. It's been really fascinating to watch and just fantastic for me as a physician to see.
As far as Pegvisomant is concerned, in your view, is that drug underutilized? And if so, why?
Yes, so I think Pegvisomant initially was being developed as a add-on or second level medical therapy for acromegaly. I could tell you that when we wrote the Endocrine Society acromegaly guidelines, we had a number of discussions about the positioning of Pegvisomant. In fact, even said that given its efficacy, which is pretty good at controlling IGF-1, that it could be used even as first-line therapy on patients. I think where it tends to be used, at least in the United States, is in those patients who have, I would say, partial response to one of the somatostatin receptor binding medications like octreotide or lanreotide, and is usually used as add-on combination therapy. And it can be used as isolated monotherapy if patients have zero response to octreotide or lanreotide type products. In Europe, it's only approved as second-line therapy, and that's how it's regulated and allowed for access in Europe. So I think it is underutilized. It's a terrific medication. I think one of the reasons it's underutilized is that many physicians have been, I don't think as much anymore, but had been uncomfortable with using a medication that does not target the tumor itself and bypass the tumor and blocks growth hormone wherever it goes. And they're asking the question, well, if you do that, will the tumor grow? And the good news is we have now a lot of data that shows that if these tumors grow, it happens only a very small minority of time. And if it does, it's only a little bit. So patients do well with this. I think that's been one concern. And the other one is patients have to give subcutaneous injections to themselves to do this. And in many patients with acromegaly, there may be arthritis, maybe hand joint problems that make it challenging for patients to self-administer drug. And I think that has made it in some ways challenging. But it's a terrific medication. And almost the vast majority of patients is really well tolerated and works really well.
That is so good to know. I'm going to switch gears just a little bit right here, Dr. Katznelson.
Yeah.
Acromegaly and Cushing's disease are both rooted in pituitary tumors, yet they present very differently. But misdiagnosis is a real issue in the pituitary community. Have you seen patients who were given the wrong diagnosis between these two conditions? And what leads doctors down the wrong path when that happens?
Well, that is such a good question, Tony. Both of these disorders are highly underdiagnosed, and there's several reasons why that is. Acromegaly is such a slow changing disorder where if you look back at photographs and look back at medical complications, patients have had acromegaly probably somewhere between 6 and 12 years at least before they're diagnosed. And that's because the changes happen so slowly. And even though you could say, oh my God, it's obvious someone has it, when someone's looking at themselves in the mirror for all those years every day, you just don't see the kind of what we call insidious, slow changes that happen. And what tends to happen is patients, if you look at what brings them to the doctors, they don't come in and say, you know, I've noticed changes in my face, or my hands have gotten bigger. I've had to cut my rings. My shoe size is changing in acromegaly, which happens quite often. And because patients don't say this, it doesn't trigger in their general doctors or the gynecologist or their dentists, boy, there's something wrong here. There's something we should be thinking about as another cause. Or the dentist, why are the teeth changing? Why does someone need new dental work, new orthodontia work. They just tend not to think about it, and by no means being critical of these physicians. It's just such a rare disease, and they may have read about it once in medical school or heard a lecture about it years before, and they're just not thinking about it. And by the way, I think that's where the internet and AI can come in handy for patients to self-advocate. But back to your question, so acromegaly goes a long time and is just diagnosed as someone with hypertension, with diabetes, with headaches for who knows why, and the diagnosis is just missed. I saw one patient years ago, her tongue was getting so big in her mouth that it wasn't fitting in her mouth, and she had a doctor who was advocating for actually tongue resection, believe it or not, so the tongue could fit better in her mouth. And luckily, thank God, she saw some doctor who thought maybe there's another cause of this. And the same goes for Cushing's. Many patients with Cushing's present saying I've gained weight, or I'm getting women who are getting extra hair growth. Well, gaining weight's common in this country, in the Western civilization, and hair growth, unfortunately, is relatively common too. And the physicians just don't think about it, and they're and women are given the diagnosis of having polycystic disorder or just being heavy, unfortunately. And that's another disease for these reasons that are heavily underdiagnosed.
Yeah, hopefully we can get a lot better at getting these diagnoses earlier, which is my main goal behind this whole podcast. Moving forward, you helped develop a new way to categorize pituitary tumors. In plain terms, why does it matter how we label and classify these tumors? And how could it help acromegaly patients get better care?
Yeah, so we've had a lot of thought and discussion about how to label the different aspects of the disease, particularly, for example, the pathologic approach to these tumors. And I'll tell you why. When I started doing this, it's a lot like patients who have cancers. These aren't cancers for the vast majority of cases, but cancer, the chemotherapy for cancer was always just hit them with whatever medication we have, just pound them and see what happens. But we've gotten better. at brain cancer patients, and we've got a lot better at patients who have pituitary tumors because we can personalize the approach much better. We can be a lot more precise about how we approach the therapy. For example, there are pathologic markers that will give us some guidance one way or the other if the patient may respond to one of the somatostatin receptor type medications, like octreotide or lanreotide or pasireotide. We've got these, there are MRI markers that can give us a sense of whether someone will respond well. There's genetic markers that may give us a sense not only of genetic predisposition, whether this patient may have children and they may be at risk for having acromegaly, for example, but these markers are allowing us to be a lot more precise in how we approach it. And so these markers are used as categories, so we can categorize them by molecular markers, by pathologic markers, by imaging markers, by degree of invasion on the MRI scan, by symptoms. So if a patient has headaches, it may make us go down one path versus not having headaches. Um, and there's been several different nomenclatures given to the tumors. More recently, the World Health Organization has used the term PITNETs, which I understand where that comes from. PITNET means pituitary neuroendocrine tumor, because these are called neuroendocrine tumors. The problem with that designation, in my view, and why it's a controversial designation, is that it makes people feel like they have a neuroendocrine tumor kind of cancer, and makes people feel like they're in the same bucket as someone who's cancer, but it's not. These are not acting like cancers. They are certainly super impacting this person's life, but we're not thinking about, oh my God, there's a cancer that's going to metastasize. It happens so rarely. They're not. So I'm challenged by or I don't agree with that type of designation, but nevertheless, that's a designation that's out there. But it does help us, along with the other markers, categorizing patients, so we can sit down and say, you have this marker, you have that finding, you have this and that. And therefore, I'm recommending this path for therapy because we can show that you have a better chance of responding because of these markers. And I think that's important in our approach.
I think so as well. You mentioned a little bit about misdiagnosis. What are the most common mistakes in acromegaly management that you've had to help patients recover from when they come to you for a second opinion?
Oh, there's several different ways to look at this question, Tony. It's a really good question. The first is not having a diagnosis. Patients who have had a pituitary tumor they've been operated on, but their patients are asking, why do I still feel so crummy? Is because they weren't diagnosed in the first place correctly. Another problem is having the right surgeon. And I can't even tell you how important this is, having a surgeon who is experienced, someone who does a lot of these per year, uh, who has outcome data. So for a patient, these are the questions that the patient should be asking their surgeon. How many do you do a year? How many have you done total? What are your outcomes? What percentage of your patients develop normal IGF-1 or don't require any further therapy? Or even if they do, got therapy pretty soon after the surgery, so they didn't have to wait years and years for the next steps of their pathway. We have data that shows that the more experience of a surgeon, the better the outcome is of the surgery. So that's another place I see, because I see patients who come to me and say, I had surgery and look, I still have the disease, and I look at their MRI scan and say, "Oh my god, what was removed in the first place? It looks like the same MRI from before surgery," or very little was removed. And that's because of the level of experience of the surgeon. And there are surgeons who've gotten so good internationally at not only removing what's visible on the scan, but also removing pieces, the wall of the cavernous sinus called the dura, the medial wall of the cavernous sinus, which by itself can improve patient outcomes. So having the right surgeon makes a big difference. That's one other one. I think another mistake, and we see this in clinical studies that we do, when we compare clinical studies for medical therapy on studies or this protocol is to say, okay, this is the dose you're going to take. We're going to change the dose if the IgG1 looks like this. So it's set protocols versus studies where we just ask patients how they're doing, what medicines they're on. What we see as mistakes is that the physicians tend not to dose titrate correctly the medical therapies, maybe not as aggressive as they should be, or not using combination therapy as they should be. And so what happens is that patients are being inadequately treated. And that's just because of lack of experience of the physician. I'm not saying they did something wrong, but they didn't do it right. And that's because of inexperience. So those are the major ways I see when patients come to me and say, "Oh my gosh, why am I still feeling like I am?" Well, we could upgrade your treatment, and that's what we try to do.
I'm so happy that you mentioned what patients need to ask their doctor and what it means to have the right surgeon. Those two things cannot be mentioned enough. I don't mind having that conversation in each podcast that I host. Let me ask you this, Dr. Katznelson. Many acromegaly patients end up with some degree of hypopituitarism, either from the tumor itself or from treatment. How do you manage all those hormone deficiencies at the same time without it becoming overwhelming for the patient?
Yeah. So there's several things that I try to advise our trainees, our fellows, and other physicians to think about in approach to this. First off, if a patient develops hypopituitarism, which means that the rest of the pituitary gland, either part of it or all of it, is not functioning adequately. So patients may have to take some replacement therapy, and that could include thyroid. It can include a little bit of steroid, such as hydrocortisone. It may include estrogen in women, testosterone in men. It may include fertility treatments. If a woman wants to conceive or a male wants to have adequate sperm, this is all part of having low pituitary function we have to think about. So I advise first to physicians when they're approaching patients and to patients themselves. Unfortunately, you have to think of this as a chronic thing. It's not going to go away. Once it's there to stay. And so think of it like high blood pressure or high cholesterol is you're just going to have to be on medications. It's more involved than high cholesterol, but it's nevertheless think of it that way in your head. And we've had patients have therapy to help them get under their skin and get into their head that this is going to be something that they just have to do. It becomes part of their daily life from here till hopefully the next 50 years. That's one piece of it, kind of the psychological approach of just uh, understanding the fact that this is here to stay. And that's important, not easy for a lot of people. Another piece of this is we try to create paradigms where this fits into the lifestyle. It does not impede the lifestyle. I tell patients, my goal is to give you a strong quality of life. What's important in your quality of life? What kind of lifestyle do you have? If are you like a marathon runner? So we have to whatever we do, we have to think about how you approach exercise. How are you a young woman that wants to become pregnant? Well, if that's your goal, then what kind of therapy do we need to do to get you there, to get you to conceive, to get you through the pregnancy, and how do we manage it afterwards, once you've had your delivery, before the next baby? Uh, and so all of these kind of fit into if you're a male, and one of the consequences of hypopituitarism is a low testosterone level in a male, and what that will present with low libido and low sexual function, but could also present with low sperm counts and infertility in that way. So, are you a young man that wants to have children? And so we have to think about it's a different pituitary hormone replacement if we're trying to increase sperm counts in a male versus just giving them testosterone, which is easier to do, to restore fertility and exercise capacity and strength and bone strength and aerobic capacity. So all those things um, we have to think about. So when we approach this, I usually do it the minimal therapies at first to see what it takes to make someone achieve the quality of life that they would like to have. Usually, it involves a little dose of hydrocortisone, and we tell patients It's super important you take this the moment you wake up in the morning, because if you don't, you'll get behind the rest of your day. Have it by your bed with a cup of water, for example. Uh, Thyroid pills, how to take that, and what are the challenges of taking thyroid pills in terms of what other medications or minerals do you not want to take at the same time. Uh, and then going down the path of the kind of the more sexual function, having children, not having children, making sure that someone is adequately estrogenized, or in a male androgenized, have enough testosterone. So it's a case by case approach, but really with the goal of trying to ensure that the patients have a strong quality of life. That's what we really want here. And how do we get there with minimal attention and aggression?
I'm going to take a step back a little bit, Dr. Katznelson. You mentioned just a little bit about AI. With AI entering radiology and lab interpretation, how do you see AI changing the way pituitary tumors are detected and monitored over the next 10 years?
Well, AI is everywhere, for better or for worse right now. And let's work on the supposition that it's for better, and that we can use it in some ways, or patients can use this to try to make their lives better, which they should. We have the capacity at our fingertips. Why not use it? So one way, which has been really interesting, has been using AI for earlier diagnosis. Interesting papers have come out using facial recognition software and AI to look at photographs. And when you do this and you apply studies of using AI and facial recognition software, uh, you can pick up, if you look back at photographs and look, you could have picked this up years ahead of time using AI and facial recognition software. So this is a future state of using software that's already out there, and there's already cameras everywhere, of using this to try to detect earlier. And with acromegaly, the earlier you pick it up, the better you are, because we just said earlier that patients may have had disease for 6 to 12 years before it's diagnosed. So if we can diagnose this earlier, less complications, less changes in the body, easier for the patient, probably smaller tumor. How else it could be used is AI is being used all the time online for patients, A, to get a diagnosis. They're plugging into these AI platforms, into ChatGPT, for example, or Gemini, that I have the following problems. What are the causes? And AI can just spit it out. And I've had a number of patients who have presented because they made a self-diagnosis using AI. So now AI can tell you the wrong answer. All depends on the prompts that are used, and so you got to be careful with it. Like you always have to be on the internet because you can misdiagnose. But I think it has enhanced the sensitivity of diagnosis, and patients can advocate for themselves. Another place that AI is useful, really useful, is in therapy. So again, there's all these medications out. We were talking about this earlier. Should I use this medication, that medication? When should I have radiation treatment? We didn't discuss that, but radiation treatment is another option for patients. And AI can help walk you through it. It can really help almost form an itinerary for you of what you should do first, second, third, fourth, and really useful for that. It's using tools that we did not have available to us in the past. And so patients should be advocating for themselves and should be using these tools and presenting this to their physicians to say, this is what AI shows. I'm not an expert in this, but this is what I found out. Can we walk through this together and see what works and what doesn't work, and come up with a game plan for myself? So I see AI as being a real positive in this way. Not always. It can be wrong, but I'd rather be more sensitive than not.
You just mentioned radiation. We touched on radiation while at Stanford. Can you give your opinion on radiation for my audience?
Sure. So this is another topic that comes up a lot about the role and timing of radiation and what kind of radiation to give. Traditionally, many decades ago, radiation filled the heart with dread because they heard stories of what radiation can do as dangers. But really, we've gotten so good at radiation therapy, and there's been monumental innovations in radiation therapy over the last 30 years that those old fears really are not substantiated. Not that there's no risk, but the great fears are unsubstantiated. And the real question comes back to what is the role of radiation? So radiation does not work in everybody with acromegaly. It works, depending on who you read, somewhere between 50 and about 80% of patients. And part of the reason why it doesn't work in everybody is because radiation works by killing cells largely as they're dividing. The faster a cell is dividing, like an aggressive cancer, the better chance radiation has of killing that cell division quickly. Acromegaly tumors tend to grow really slowly. So radiation, when it does work, can take years to work. So that's the second point. Not only does it not work in everybody, but it could take years, anywhere from 2 to 10 years or more sometimes to be effective. And in fact, we oftentimes reconsider further radiation. We call that a boost of radiation around year 4 or 5 if the person still has active acromegaly to make sure that we continue to treat. Uh, so that's the second point of it is it can take a long time to be effective. The third point is there's different kinds of radiation out there. There's what's called stereotactic radiosurgery or radiotherapy, that's synonymous. And this is basically radiation called cyberknife, called gamma knife, proton beams, another kind like this, where it could be given anywhere from 1 to just a few times, versus the kind of traditional conventional radiation therapy they can take daily for 6 weeks. And there's reasons why we may want to use one or the other. It's certainly a lot more convenient to have 1 or 3 days of it than 6 weeks of it. But there's reasons, but you can only do that if the tumor is not next to an important structure like the eyes, the eye nerves, because you don't want to have any chance of damaging the eye nerves, which you can get if you give a lot over 1 to 3 days. So basically, radiation doesn't work in everybody, it can take years to work, but definitely has a role. And the role is usually in the United States used as adjuvant fashion. Adjuvant means second or third line therapy in patients who've had surgery, maybe you've tried medical therapy, but the acromegaly is still persisting despite the best attempts of surgery. So we try to radiate what is left. Now, in other parts of the world where medical therapies may not be available, radiation therapy is used much more because if patients don't have access to the medications that we're fortunate in the United States to have access to, that radiation may be the way to go. And it may be that is the next step in the care. So some of this depends on region, some of this depends on economy, some of this depends upon what country in the world we're talking about, where radiation will be used more or less. But generally, it's an excellent strategy to use. Usually, again, for us, the second or third line therapy. And if you do use it, keep in mind it may take a few years for that to be effective. And during that time, someone's got to be on medical therapy. So we place the person on medical therapy, keep the IGF-1 normal, and maybe once a year withdraw the medical therapy and see if the IGF-1 remains normal. And if so, great. If not, we go back on medical therapy and reapproach us a year later and keep doing that until we know the radiation has been effective.
Conversation of radiation leads me directly into my next question. Cancer is a very real fear in the acromegaly community. And I personally know people who live with both cancer and acromegaly. The link between excessive growth hormone and cancers like colon and thyroid is still debated. And even the latest consensus guidelines haven't settled the screening question. So, how real is the risk, and what should acromegaly patients be asking their doctors right now, Dr. Katznelson?
Yeah, so the link between acromegaly and cancer has been debated for decades. What we do know is that there is a higher incidence of colon polyps. So a colon polyp, which is found during a colonoscopy, is a potential premalignant condition. So that every patient, uh, either at the time of diagnosis or shortly thereafter, should have a colonoscopy, in my view. And the colonoscopy, if it reveals colon polyps, we should probably do a repeat colonoscopy after those polyps are removed in the near future afterwards. There aren't set guidelines on this, but we often think about it, well, at least the next 2 or 3 years, you should have another colonoscopy to look for colon polyps, particularly if the acromegaly remains active. We do not have good data on whether treating the acromegaly successfully, like normalizing the growth hormone IGF-1, removes that risk of colon polyps, but there are data that there's a greater chance of seeing more colon polyps if someone has active disease. So that's one piece of it. There has been conjecture over the years that patients with acromegaly have higher risk of colon cancer. And this has come in some studies and not in other studies. We published a study in Boston years ago of about 164 patients and didn't see one colon cancer. But there's been other studies where they have. So this goes along with the fact that I do feel we should be aggressive with colonoscopies at baseline and then a follow-up because of that risk we know of colon polyps and potentially of colon cancer. There's also the story with thyroid cancer, and there have been studies which show there's more thyroid cancer in patients with acromegaly. Now, part of that is because there is more goiter. That's a large thyroid gland in patients with acromegaly, and goiters themselves can have nodules that can become cancer. So it may be that just the presence of the goiter, the nodules in the thyroid gland, which you see with acromegaly, can cause increased risk of cancer. And that's why in the guidelines that have been published, we've said that everybody with acromegaly should have a physical exam for feeling to feel for a thyroid gland enlargement, a goiter, and if there is one exists, doing an ultrasound. Now, to keep in mind, there's different consensus statements internationally. Some that say every patient should have a thyroid ultrasound, but that's how we landed with the Endocrine Society guidelines. Is if there's a palpable problem, or you can't palpate because a patient has a thick neck, then do an ultrasound and move from there to screen for thyroid cancer. Now, there's one other part of this that there has been a study which showed that in women who have, particularly in premenopausal breast cancer, if they have active cancer, active, and they have acromegaly active, that these patients have higher risk of aggressive cancers. And if that's the case, it's super important that we maintain a normal growth hormone IGF-1 in those patients because of that potential risk of cancer growth, cancer recurrence. Uh, so aggression from cancer due to acromegaly, just because maybe the growth hormone is just driving it to grow, is another risk. So I think we need to be very thoughtful and deliberate in approaching patients with acromegaly for the risk or the concern of cancer. Colonoscopy I talked about, thyroid exams with thyroid ultrasound we talked about, and if the patient has a past history of cancer, making sure we're aggressive at normalizing that growth hormone and IGF-1. Because of that, maybe it's a theoretical risk, but risk of more aggressive cancer.
Excellent explanation, Dr. Katznelson. If you could change just one thing about how the medical system handles patients with pituitary disorders right now, diagnosis, treatment, follow up, anything, what would it be?
Well, that's easy. That would be to ensure that we have a health system that would facilitate, not only help, but facilitate access of patients to the right care, to centers that have the expertise in this, to a surgeon who's experienced, to a medical endocrinologist who understands how these medicines work and how to dose them correctly, and not just rely on whoever's local in the network, which is what tends to happen. So, in my dream of dreams, we would be able to have an insurance company that says, "Oh, you have acromegaly, really? Well, there's no one in our system that really is fantastic at this. I can't say anybody here has a center of excellence, for example, in acromegaly. So I'm going to refer you to the major urban area over there and get care where there's a major medical center." That would be my dream of dreams for patients with acromegaly.
Sounds good. Dr. Katznelson, we are at the point in this conversation where we have reached the rapid fire five. Are you ready?
Okay, I'm ready.
What would you be doing if you weren't a doctor right now?
I love music. I'd love to play acoustic guitar.
while you're in the office? Is it coffee, tea, or something else?
Super easy, coffee.
Early bird or night owl?
Earlier the better.
If I handed you a free plane ticket right now, where would you go?
Kilimanjaro. I am dying to hike up Mount Kilimanjaro.
Sounds like a great idea. What's the most used app on your phone besides your email?
Okay, this is just between you and me. The New York Times Wordle.
I
It's our
won't tell a
secret.
soul. Sounds good. Dr. Katznelson, your name is one that is deeply respected throughout the pituitary community, and for good reason. Your decades of work in endocrinology, your leadership in the field, and your dedication to advancing the care of people living with acromegaly and other pituitary disorders have made a lasting impact on countless lives. Keep doing the good work that you're doing. And to my audience, make sure to support the channel by hitting that subscribe button, liking this video, sharing it with others, and leaving a comment below. You can also follow me on all my social media platforms and stay right here for more real conversation, expert insight, and inspiring stories. Dr. Katznelson, thank you for your time. Thank you for joining me today. And most importantly, thank you for talking acromegaly and pituitary with Tony. It's been a pleasure having you join me today.
It's been my honor, Tony. Thank you for inviting me here. Thank you.
The pleasure is all mine. If you're ready for another powerful conversation about being diagnosed with acromegaly, click here and watch my conversation with my good friend, Rissa August. Thanks for watching.